Well, my name is Keme Carter, and I am really delighted to be here with Nicole Dubosh to talk about a very important topic, communication in crisis, teaching our trainees to adapt their communication practices in the age of COVID. And here's the outline. This is where we'll be going over the next 20 minutes. We'll start with providing some background on the impact of COVID on clinical communication, and then we'll move into providing you with some training interventions and a toolkit to help your learners communicate in crisis. And then we'll end with providing some examples of how you can assess your communication training. By the end of this talk, we hope that you'll be able to describe the impact of COVID on physician communication with patients and their families, discuss ways in which crisis scenarios alter best practices for patient communication, and then list strategies for teaching patient-centered communication in crisis scenarios. But first, I think it's important that we acknowledge the many barriers to effective communication that currently exist, and I'm going to group them into four main categories. The first being personal barriers to effective communication. There may be limited conflict management skills or high levels of emotion, self-confidence issues, fear, and I think that we can all agree that as emergency physicians, we've gotten an extra dose of fear and uncertainty over the last 2 years. And those high levels of emotions can serve as barriers to effective communication. There are systems level barriers that include high workload, high acuity setting, time pressure. I'll add to that constant interruptions. And those things together really do characterize the ED work environment in a lot of cases. You see here a list of interpersonal barriers to effective communication. I'm going to focus on lack of familiarity because that could mean lack of familiarity with the patient that you are encountering or that your learners are encountering, but also lack of familiarity with communication best practice, which brings us to training. We know from the literature that across the continuum of medical education, at best there is variability in training, but there is also a lack of deliberate training, deliberate feedback to help our learners really refine their communication practices. So consider for a moment this scenario. You have a resident physician, and at baseline, during normal pre-COVID times, you know her to be knowledgeable and effective, a solid, good communicator, although you may not have assessed that formally. But during COVID, she is exhibiting signs of being emotionally and physically exhausted. And as she's preparing to go in to see patients, she may not really be acutely aware of how her communication behaviors could affect her patient. So she goes in to see the patient. During evaluation, of course, she's masked, the patient is masked. She tries to remain as efficient as possible in the room to limit her exposure, but again, is not acutely aware of how she could exacerbate or mitigate the feelings of fear and loneliness that her patients may be feeling. In post-evaluation communication, visitor restrictions are still in effect to some degree in many places, and she grabs the iPad to loop in the family and the loved ones of her patients to discuss status and prognosis. And during this talk, we are going to touch on each phase in this scenario so that you can help your learners really maximize their positive impact on patients at each communication touch point.
So effective communication has benefits to both the patient and the provider. There's ample evidence out there to show that patients who perceive their doctors to be strong communicators are more likely to adhere to positive health regimens, such as smoking cessation, medication compliance, and they're more likely to report higher patient satisfaction. For the physician, there are benefits as well. Doctors who are noted to be strong communicators, this correlates with decreased risk of litigation. It's also related to improved job satisfaction, which then in turn relates to wellness and decrease in burnout. While these things have remained constant throughout, times have changed, and COVID has actually transformed the way that we now have to communicate with our patients, and thus the paradigm for teaching effective communication skills has changed. So I think one of the most obvious changes we've seen in this pandemic are some of the physical barriers that we now have to deal with, including masking, PPE, and actual physical distancing from the bedside from our patients. With face masks, I think we can all attest, especially the N95s, this results in muffled voices where we're often having to lean up against, especially our elderly patients or the patients who are hard of hearing, and basically scream in their faces in order to convey our messages. Facial expressions as well are very much blunted with the use of masks. There's a recent commentary Medley and Al described actually how different parts of the face can express emotional nonverbal messages. And when you're wearing a face mask, you're essentially cutting out the middle and lower parts of the face. So you only have that upper face to go by. So this, not only affects our ability to portray emotions such as empathy or surprise or grief to our patients, but it also impairs our ability to read those emotions on them. And then finally, the physical separation, limits some of the use of these other nonverbal communication tactics, such as hand gestures or sitting at the patient's level. And particularly in those patients who rely on nonverbal communication, such as those who depend on sign language or are hard of hearing, this really hinders our communication abilities. Telecommunication is a second thing that has now transformed how we interact with many of our patients. This affects both the doctor-patient relationship, the doctor-family member relationship, and even in some circumstances, and unfortunately, the patient-family relationship with things like virtual goodbyes and end-of-life discussions happening through an iPad. So this was an interesting qualitative analysis that actually, in the geriatrics literature, that sought to describe some of the characteristics in the COVID era at end-of-life communication that contributed to effective or ineffective communication. So 324 families of veterans were surveyed. They noted that high-quality communication was characterized by staff availability and being kept informed of the patient's condition. Whereas low-quality communication was thought to be due to or related to limited access to staff, insufficient updates, and lack of shared decision-making in the care plan. What was interesting is that the effective video communication was seen as both a positive in some aspects and a negative. So I think that's one of the realities that's here to stay, and we need to kind of highlight what the attributes, what the positive and negative are. So the whole topic, finally, of difficult discussions has become even more difficult now. For one, we have physical space limitations due to patients boarding, overcrowding, physical distancing in the patient care areas that are now often overflowing into our family room spaces that we historically would use for these discussions. We have staffing shortages. So in particular, a lot of our allied healthcare providers like social workers are not on site all the time. Extra nurses to provide support for these discussions is very hard to come by these days because we're often short-staffed. I think most of us during medical school learned that tried and true Spike's mnemonic for breaking bad news, which includes getting the perfect setting, getting everybody involved and ready. But unfortunately, it's a reality now that we don't always have those resources to have these discussions. The topics that we're discussing are different. We are now having end-of-life discussions earlier, particularly at the beginning of the pandemic when we didn't know very much about this illness and the trajectory that it would take in some of our elderly or immunocompromised patients. We're having discussions about resource allocation and crisis standards, topics which we never even had to learn about in our medical training or practice on, prior to COVID in our careers because it wasn't a reality, but now it is. Many hospitals are starting to, will have during the surges, their crisis allocation protocols and what the guidelines are, and it's really important for that doctor-patient relationship for us to be transparent with our patients and discuss these, even though it's a very difficult topic to approach.
So the first framework that we are going to provide for you is a framework to foster connection with patients. It's important, at baseline during pre-COVID times, but it is especially important to teach our learners how to foster connection with patients during these times of crisis. Now, the first step is to teach your learners to prepare with intention. And we should really be teaching them that they need to ask themselves, am I prepared to have a meaningful interaction with this patient? And that includes preparing by familiarizing themselves with the patient and the medical record, but also really creating a ritual to help them minimize distractions and focus on the patient at hand. The next step is to teach them to listen intently and completely. This, of course, includes optimal nonverbal communication, which I'll touch on the next slide. But it also includes teaching them to minimize disruptions or the number of times they interrupt the patient during an encounter. We want to teach our residents and our medical students to really seek out the values and the goals of the patients that they are caring for. And to the best of their ability, really incorporate those values and goals into the care plan. Now, this becomes a little more nuanced and a little tricky during times of crisis like COVID, and we're going to touch on that shortly. The next step is to teach our learners to connect with the patient's story. They need to ask themselves, how can I have a positive impact on this patient's medical journey? And with that, they need to actively and explicitly acknowledge the patient's own efforts within their healthcare journey, but also acknowledge those circumstances that are beyond the patient's control that are affecting that patient's presentation and healthcare as a whole. And then lastly, teach them to explore emotional cues. It is a little bit more difficult with our face being masked, but it is still possible. We should be teaching them to really notice, to name, and to validate those emotions that their patients are exhibiting. So effective communication really does require a sophisticated skill set. And nonverbal communication in particular is critical, it's crucial, and it's important in how we communicate empathy. So as Nicole mentioned, the mask limits how we can communicate nonverbally with the bottom half of our face, making mutual gaze and body language and positioning all the more important. We should be teaching them to maintain mutual gaze. Overall, patients receive and perceive mutual gaze, eye contact positively. There is some nuance and exception to this I'm going to talk about in a second. With regards to body language, teach them to sit at eye level, to uncross their arms and their legs, to lean in, practice the head nod. Those behaviors actually validate what the patient is saying and build connection. Now, optimal nonverbal communication actually can vary across cultures. And as educators, we need to be teaching our learners to be aware of their own cultural biases, and we should be helping them mitigate how those biases influence their care of patients. And we should teach them that, again, these nonverbal communications of empathy can actually vary a little bit. For example, the length and directness of mutual gaze can actually carry different meanings across cultures. So again, as educators, we need to represent not only the cultural norms of the dominant culture, but we need to be representing the cultural norms of the diverse patients that are represented within our communities.
So as I mentioned before, verbal communication is significantly affected with some of the changes we're now seeing in the clinical setting. So it's important to emphasize those attributes that we can actually affect despite the masks and the PPE and the distancing. So it's important to teach your learners, make them aware the need to speak louder and to speak slower. You want to ensure that they're verbally delivering small packets of information so the patients can process these with limited nonverbal communication. You want to make sure that they avoid bearing bad news. You might, when delivering bad news to the patient, they need to be direct in order to ensure that that verbal message is getting conveyed, because we are limited with some of those other nonverbal communicating tactics. And then finally, utilizing some of the talking map tools about these new and difficult topics. So these are two talking maps for communication that were recently published. The first one is the Calmer map. This is a map for talking about COVID-related proactive planning. And essentially, you want to check in with the patient. You want to ask them about COVID, what they know, what their concerns are. Lay out the issues. Be very upfront about this. Motivate them to express their desires and to choose a healthcare proxy. Expect emotion, and again, recognizing some of the limitations with that, and then record or document the discussion. Similarly, the SHARE technique is a talking map for explaining resource allocation. Again, another brand new topic for many of us. You want to show them your institution's guidelines, if it exists, headline what it means for the patient's care, affirm that you are still going to take excellent care and think about compassion and treating their pain, et cetera, despite some of the limitations. Probably most importantly, emphasize that the same rules apply to everyone, and this guideline was developed and is implemented across the board. And this, again, can be really helpful with this new topic that we didn't train on in our education. And here's just an example of some visual depictions that can actually be helpful when you're teaching your residents and your students. And I think, kind of the bottom line is just really acknowledging that telecommunication is difficult, video is not ideal, and setting the stage for that discussion with that. So as educators, we need to continue to think about best practices as we do for every sort of curricular development or competency that we teach. So we want to make sure that we have available staff to our students and our residents, whether that be in person, if that's not feasible, to have a virtual method for education and teaching. We don't want to just jump ship and avoid teaching this competency because we can't actually be in person for it. We want to ensure a seamless flow of information. You want to make sure that when we are using telemedicine techniques and video communication, we have adequate technology and advocating for that in your programs through your medical school or your institution. And then continuing to assess our new methods, because that's really important to see if these new tactics we're using for education actually do play out and improve the competencies.
So as you think about implementing a communication training program, we have some recommendations. The first is that you provide an opportunity for your learners to really reflect on their existing communication behaviors and how those behaviors may influence patient care. Introduce the frameworks that we've provided to you on building rapport, nonverbal and verbal communication, and best practices for processes and procedures. And then, of course, incorporate some structured practice. This can be done virtually or in person. You can do an OSCE-type format or a communication boot camp. That's especially helpful if you're moving large cohorts of learners through your training. And then always provide structured feedback to help them really refine those communication skills. Now, COVID certainly has necessitated us moving from in-person learning formats to virtual learning formats. And when you are assessing your curricula, of course, assess skills, performance, learner satisfaction, their self-reported preparedness to engage in those communication behaviors. But should your learning format change from in-person to virtual, we really do need to make sure that we're maintaining the quality of our training. And we did this at the University of Chicago with our Advanced Communication Skills Boot Camp, in which all incoming interns across all specialties must participate. In 2019, we had our Advanced Communication Skills Boot Camp in person, and of course in 2020 we moved that to a telesimulation boot camp. But with each boot camp, both the in-person, that was 2019 Advanced Communication cohort, and the 2020 telesimulation boot camp cohort, we assessed the skills, performance, learner satisfaction, self-reported preparedness to engage in those communication behaviors, both right after the boot camp and then 3 months into practice. And then we compared the two, and we were able to assure ourselves that maintaining this boot camp virtually really retained the quality of the training intervention. So in conclusion, communication training is absolutely necessary. COVID has magnified these communication challenges within the ED work environment, but there are frameworks that exist to help us mitigate those challenges for our learners, and continued assessment of training interventions is needed. Thank you, and we're happy to answer any questions.